she said I will be presenting perinatal mood disorders, specifically depression, anxiety, and OCD in the perinatal period. Oh, why is my slide not going? Well, I do not know why my slide is not. Why is my slide not going? Here comes Olivia. Just do that. Okay. Okay. So this presentation aims to shed light on perinatal depression, anxiety, OCD, emphasizing and identifying symptoms, understanding their impact on expectant and new mothers, and highlighting nuances in symptom presentation, the strategies for effective management, and we will discuss all of that. Our objectives are to examine the psychological connection with pregnancy and the onset of perinatal mood and anxiety disorders, also known as PMADs. I'll also discuss signs and symptoms of psychiatric disorders during the perinatal period and the use of appropriate screening methods. And then I'll also discuss strategies for prescribing and follow-up care. So the perinatal period is the period of time when you become pregnant, and usually up to a year after that conception. A couple statistics is that maternal mortality has increased 23.8% in the United States recently. 99% of maternal mortality is preventable. 8% of pregnancies that are 8% of pregnancies that are related to death are usually by suicide. 40%, 46% of suicides most likely occur 6 to 12 months postpartum. 8 to 17% of suicides occur in the first 6 weeks postpartum. The most common method of suicide is hanging and firearms. So we really want to identify this population. You can see the risks, and it's really important to identify a person dealing with anxiety and depression in this period. So in pregnancy, we know now that hormones are very powerful neurosteroids. It is not the level that causes changes in mental health during this time. It is the fluctuations of them in women. So there is a vulnerability to react to the shift of these hormones. That's also why we see mood changes in perimenopausal women, menopausal women, because of that fluctuation in hormones. So there is a vulnerability to this, and in the postpartum period, particularly in 24 hours, that estrogen and progesterone that is maintaining the pregnancy pretty much decreases by 100% within the 24 hours. So that is a huge hormonal shift, putting persons bearing a child at a high risk for having mood disorders. Just a little bit of background on just changes in pregnancy. We know that there are a lot of body changes in pregnancy, and they can affect your mood and anxiety. The cardiovascular system, for instance, you usually have an increase in blood volume, and that blood volume increases as the pregnancy progresses. Therefore, there is usually a decrease in your hematocrit, mostly due to a dilution effect. Patients can complain of being tired due to these changes in their hematocrit, kind of like an anemia. They can also, the cardiovascular system, they also have an increase in cardiac output, so they can complain of shortness of breath. So these changes do affect prescribing because of the dilution effect. So when we do start prescribing for anxiety, depression in the perinatal period, we need to keep in mind of these cardiovascular changes and this kind of dilution effect. So we'll need to titrate to maximize the doses during pregnancy, leading up to a lot of times to the third trimester, and also postpartum. We oftentimes also adjust the med dosage based on the pregnancy dose versus the postpartum can sometimes be very different because of these changes in the cardiovascular system. In the respiratory system, often women, as they're pregnant, they have a lot more mucus, they seem more edematous, there's a decreased pulmonary function, and this can affect their mood and anxiety due to the decreased oxygen levels, and it can increase anxiety and worsen depressive symptoms. Endocrine system is also increased level of neurosteroids, and neurosteroids are really what we also look at that affect our anxiety and our mood. And then sleep. There's a lot of sleep changes. Pregnant women often complain about difficulty sleeping. Put a mood disorder on top of that, where they're having ruminating thoughts of anxiety and not sleeping much. And so increased insomnia and daytime fatigue can also affect mood. When there is underlying anxiety, GAD, like generalized anxiety disorder, and a major depressive disorder, if a woman already has underlying anxiety and a mood disorder of depression coming into pregnancy, these conditions are often exacerbated due to these psychological changes, physiological changes. So this is just a quote that I kind of like. A healthy, normal pregnancy can be the only stressor you have, and that actually puts you at risk for a mood disorder. 1 in 5 pregnant or postpartum women are diagnosed with a mood or an anxiety disorder. So what are the risks for untreated PMADs? So the risks to the mother or the person carrying the child, if they do not have their condition treated, they have a higher chance of having an operative birth, like a C-section. They have a higher chance of developing preeclampsia, gestational diabetes, the maternal suffering just from trying to manage anxiety and depression can be very hard on them. There's often relationship discord. There's a lot of times substance abuse because persons tend to go to substances, to alcohol or drug use, to help control their anxiety and depression. They're missing appointments. Oop, I have a typo there. Apologize for that. They're missing appointments and work. And of course, they are dealing with anxiety, depression during this time. On the baby has a higher chance of having an earlier birth, low birth rate, slow cognitive emotional development. A lot of times there's poor mother-infant bonding. There can be some learning disorders and ADHD, behavioral disorders associated with a baby born to a mom or a person that birthed them that had a lot of anxiety and depression during pregnancy. They tend to miss well baby visits. There can be a reduced immune resistance. Some of that is due to breastfeeding can, as we know, mother's immunity is transferred via the breast milk, and infants that are breastfed get the benefits of that. But also just the stressor that the baby is under with the higher cortisol levels that mom has during pregnancy with anxiety and depression that can affect the baby's immune resistance. And then there is some evidence showing that babies later on can have some depression and anxiety as they get older. So we always talk about what is the risk of treatment versus the risk of not treating myself and my baby. And that's sometimes a really good approach when patients are on the fence of, well, I really don't want to take medication during this time, really worried about how it's going to affect the baby. I often say, you need to ask yourself of the risks for you and the risk for the baby. What is the risk of treatment versus the risk of not treating yourself and the baby? So risk for PMADs, the actual risks that you can develop a perinatal mood disorder during pregnancy is anyone that has a history of depression, anxiety, or trauma coming into a pregnancy is at higher risk of having another episode or a continual episode. Current or prior intimate partner violence or abuse, they're more at risk of developing a PMAD. Lack of social support, low income, low education, a single parent or a teen parent, LGBTQ, IA plus parents, really because of social support, then maybe lack of that social support, have a higher risk of developing a PMAD. Smoking, if it's an unintended pregnancy, and of course, impaired sleep. In the postpartum period, the risk of a PMAD is if you had extreme stress during pregnancy, also untreated, anxiety and depression during pregnancy, a difficult or traumatic delivery, a preterm delivery, a NICU admission, already having anxiety and depression, low social support, a family history of postpartum depression. We always do, when we do our psychiatric evaluation, always look into the family history, because we do know now genetically if paternal, maternal, close paternal, maternal relationships, moms, dads, aunts, uncles, if there is a familial history of depression, anxiety, other mood disorders in the family, you have a higher chance of having a mood disorder during pregnancy or even having postpartum depression or anxiety. Like I said before, a history of a depressive episode really puts you at risk. When you have difficulty breastfeeding, a lot of times women or the person that had the child have a lot of guilt and anxiety around breastfeeding in general, and puts them at risk. And then impaired sleep. There's that impaired sleep again. And I know Shannon, one of our providers, in August talked about how important protective sleep is during this period. So when do symptoms typically start? 27% of women enter pregnancy with anxiety and depression. 33% of women develop symptoms during pregnancy, and about 40% of women develop symptoms postpartum. We've all heard about baby blues. So are baby blues the same as PMADs? And the answer is no. 70 to 80% of postpartum women will have baby blues that usually resolve within 1 to 2 weeks after birth. Baby blues are considered a normal experience related to hormonal changes after birth. So it's usually that hormonal change, that shift of the estrogen, the progesterone, and other hormones that can cause that 2 weeks of baby blues, about 2 weeks, 1 to 2 weeks. It usually resolves without treatment. During that baby blues times, if they're experience the symptoms of what we call baby blues, there is no serious functional impairment, okay? And suicidal ideation would not be seen. So symptoms common of baby blues, and a lot of times it can be from sleep deprivation as well. They will just not feel as happy. not so overjoyed with having this baby, and tired, some crying, but they definitely do not usually have suicidal ideation. Postpartum depression can have many similar features to baby blues, but the symptoms of postpartum depression are more severe and prolonged. They last longer. And that these symptoms lasting longer, and clearly thoughts of self-harm or suicidal ideation should be identified and treated. So a good rule in baby blues is patients tend to retain an overall positive outlook and healthy bonding with the infant. Whereas in clinical depression, patients do not have a positive outlook. They experience sadness, loss of interest, a lot of hopelessness, and possible and impaired bonding. So common screening tools that we use are listed right there. I think in general, OB offices are now, we work very closely with the military in the Norfolk, Virginia Beach area, and the military OB clinics are doing the EPDS now, and they are flagging people that they refer on to us when they're worried about their score. And I'll just go over a little bit. So the EPDS is the Edinburgh Postnatal Depression Scale. It's probably one of the best tools that targets depression or anxiety during this time in the perinatal period. And it screens for depression, and it's validated in pregnancy and postpartum. So you can use it during pregnancy and then in the postpartum period. It's a self-report. The patient fills it out themselves, and there are usually 10 items that they ask, and it includes questions about self-harm. And usually that is what flags OB providers, even pediatricians, to get them in to see a mental health provider if they're talking about self-harm. The score, if it's less than 9, a mood episode is unlikely. You always ask about how's your sleep, how's your appetite. If it's like a 9 to 10, a 9 to 12, that's indicative of mild depression is likely. That warrants a psych evaluation. And often when we do get these patients that scored higher on their EPDS, we will do the other screening forms as well. The GAD for anxiety, the PHQ-9 for depression, the MDQ for a mood disorder, the audit and the assist for alcohol and drug use. Okay, so perinatal depression. The most common perinatal depression is considered one of the most common complications of childbirth. It affects about 15% of childbearing persons that have a baby. Symptoms include very similar to depression in general. Symptoms would include appetite and sleep changes, decreased energy or motivation in normal activities, crying, weepiness, feelings of hopelessness, worthless, helpless, inappropriate guilt. They can have some irritability and anger, intrusive thoughts of harm to the baby. And these intrusive thoughts, the difference with in perinatal depression, intrusive thoughts are usually focused more on harm coming to themselves, to the baby, or to the partner. So, for instance, while they're pregnant, they usually, worry that if the baby's going to be okay, if I'm going to be okay going through childbirth, and that heightened kind of anxiety associated with that, or either harm coming to something happening to their partner, and then they won't be able to get through this. But those thoughts of harm are always focused more on themselves, the baby, harm coming to them, and not thoughts of you harming them. I hope that makes sense. When Olivia talks about psychosis, postpartum psychosis is more associated with possible them harming the baby or harming themselves, whereas intrusive thoughts during this time in the perinatal period and with perinatal depression and anxiety, it's thoughts of the harm happening to themselves, that they're just having these thoughts of doom and gloom. We also have little interest in caring for the baby and are detached and difficulty concentrating and making decisions, which is a very common depressive symptom in general. I also want to talk about perinatal anxiety, because perinatal depression and perinatal anxiety we treat initially the same with SSRIs, and I'll get into that. So that's why I'm kind of clumping them together. Oftentimes with postpartum anxiety, they have some depression, not always, but they kind of go hand in hand oftentimes. So they are treated initially the same with SSRIs. Perinatal anxiety affects about 6 to 8% of women. Those symptoms are fears about the health of the baby, fears about the hospital and the healthcare experience, concerns about well-being during pregnancy, and concerns about the delivery experience and transitioning into parenting. First line of treatment for perinatal anxiety and depression is actually outside of medications. Usually we will try to start initially with non-medicine options. And those would include eating a healthy, balanced diet, drinking plenty of fluids, taking multivitamins with folic acid and vitamin D supplementation, encouraging exercise, walking, or just your regular exercise routine. And to also find support groups or seek therapy, like a CBT. Non-medicine options are always important to try to start with. Oftentimes, in this period, they will need medication to help with the anxiety and depression, but we still always encourage to, even if you are taking medications, to still do those non-medication options alongside with it. So our first line is usually SSRIs and SNRIs, and you always, of course, want to consider the risk in pregnancy and in lactation. Okay, like I said, because we kind of treat OCD also along with the same with perinatal anxiety and depression, I'm going to talk about OCD too, and then I will get into kind of the nuances of treatment for all of these conditions. 1 second. So perinatal obsessive compulsive affects about 4% of women. Okay, the diagnosis criteria is pretty much about the same that you would diagnose for OCD, but this is occurring, during the perinatal period, and there is currently no specifier for with peripartum onset for the diagnosis of OCD in the DSM-5. However, the manual does discuss the possible onset and exacerbation of OCD symptoms and symptoms that can interfere with the mother-infant relationship in the peripartum period. The onset for this is usually abrupt. It's abrupt onset during pregnancy, or most common within the first 4 weeks postpartum. Typically, it presents with disturbing, intrusive thoughts and images, often of harm coming to the baby, and it can cause extreme distress in the mom. Like I kind of talked about a little bit on the other slide, these thoughts and compulsions are usually ego-dystonic in nature, meaning their compulsions, they're expressed, they're more of thoughts of harm coming, not of harming you wanting to harm the baby. So they're unwanted thoughts, they're distressing thoughts, and they reflect opposite of what your values and desires usually are. They are distinguished from infanticide ideation or psychotic delusions in that the patient usually preserves the insight that these are distressing thoughts. She doesn't want to do anything to her baby. She's having these thoughts. They're scary. They cause her anxiety. Some very common thoughts are like, I'm walking up the stairs holding my baby, and I have this thought that the baby's just going to fall out of my arms and roll down the stairs. Or thoughts of walking the baby with a stroller, and I'm going to maybe lose control of the stroller, and same thing, it's going to go down the hill in my neighborhood, and I'm not going to be able to catch up to the stroller. So then mom would probably either whenever she would take a walk with the baby, she's going to be much more increased anxiety holding on to that stroller, or she may not even go out and walk the baby anymore because she has this fear that that's going to happen. But always in OCD, they do maintain good insight. Let me make sure I didn't leave anything out on that. Oh, perinatal OCD can also be associated with impaired mother-infant relationships, and it can be associated with impaired attachment patterns and neurodevelopment of infants in extreme cases. So mother-infant interactions have been shown to be affected by early maternal anxiety in several studies. The treatment for OCD is very similar to anxiety and depression. It's therapy, and usually OCD, when they have an OCD component to it, they have, we usually have to dose higher dose of SSRIs and SNRIs, and sometimes we have to augment with SGAs, but it usually is a little bit of a higher dose with that OCD component. So SSRIs, they are the first line treatment for anxiety and depression and OCD. 97% of the population do not have babies with abnormalities, and most studies have found an increased risk. Most studies have not found an increased risk for birth defects if they take an SSRI during this time. There was a study that showed a risk of pulmonary hypertension in babies of moms taking SSRIs, but I think that was like a 2004 study. But they've now kind of come to realize that there's actually a lower risk than previously reported, and that pulmonary hypertension in the baby was often linked more to other factors going on with the baby, or even like premature births, not necessarily the SSRIs that had any impact. SSRIs have been slightly linked to poor neonatal adaptation syndrome or natal distress syndrome. That too is something that happens. It's hard to distinguish because babies tend to be jittery. Babies tend to be a little irritable, decreased tone, and have issues with sleep within that 24 to 48 hours. So there's no real clear definitive diagnosis for that. There's no treatment usually for that if they think that's what's going on with the baby, the neonatal distress syndrome. And they found treatment for that is what we have started to do now after birth is good swaddling, skin to skin protection, or skin to skin, sufficient skin to skin with mom is the best way to manage these symptoms. And like I said, it usually resolves in 24 to 48 hours. And there are no studies out there that show any risk for ADHD and autism if you take SSRIs during pregnancy. So some of the SSRIs, SNRIs, these are kind of the most common lists that we feel safe, to prescribe. It should be noted that fluoxetine and sertraline are probably one of the most studied medications on the market. And they are prescribed the most in the perinatal period. We tend to now get patients that come for a psychiatric evaluation that OBs are now starting, if they're concerned for their patient having some anxiety, depression, a lot of times we will get them on a low dose of Zoloft. It's very common with this for us to get them with the sertraline. And like I said earlier, there really are no studies out there that we just talked about that show any adverse effects. So it's best to start treating them with the proper medication. Fluoxetine, Prozac is also commonly prescribed as well. And then I've just listed all the other medications that we feel confident to prescribe during this period that has minimal adverse effects on mom and baby. SSRIs, you just need to know that, they take about 3 to 4 weeks to really show a significant change in symptoms. So always educate that when we start these medications, you're not going to see an overnight change. It's going to take about 3 weeks, 3 to 4 weeks to see any change in symptoms. Even minor changes are important. It will, I'm losing my train of thought here. Let me just see what my next slide is so I can go from there. Oh, okay. So with SSRIs and SNRIs, when you start somebody on these medications during this time, during pregnancy, you have to think about dosing and all kind of the physiological things that are happening during pregnancy with the increased cardiac output, increased, blood volume. So when you start prescribing the Zoloft, Prozac, or any of these others, you dose based on symptoms. A lot of times in pregnancy, they can be going along at a lower dose. And then when they kind of get towards that third trimester, you'll need to adjust the dose. And so we always dose based on symptoms. And then we always look in the postpartum period when have had the baby, they're still on these medications. You can also sometimes bring down the dose, not right away, but sometimes after several months, you may need to adjust the dose based on those body changes. We usually, once we prescribe these medications, we recommend that once they meet that point of stability, where you kind of hit your sweet spot, where they feel that their anxiety, depression, OCD is under control, we go from that point where you kind of hit, okay, you're taking 200 of Zoloft, you're feeling pretty good, you're feeling kind of back to that norm. We want to sit on that dose for about a year out, 12 months. So you don't have a relapse, because there's a higher incidence of relapsing into that anxiety, depression if you don't maintain for 12 months. And then always recommend if you go off the medication and taper down and go off the medication and then you get pregnant again, if you've already had one of these, a PMAD, we recommend to start medication during and after subsequent pregnancies. So the treatment goal is to prescribe the lowest and most effective dose of medication during this time. And that's it. That's my works cited. And if anybody has any questions.
Thank you, Jill. If anyone has any questions for Jill, you can feel free to put them in the chat, or you can come off mute and just ask if you like. If there aren't any questions, then we can go ahead and wrap up for today. Like I said, this will be recorded and we will place it on the VNPC YouTube channel. And feel free to visit again for the next part in the perinatal mental health safety series and our monthly webinars. Thank you, everyone, and have a good afternoon.
Thank you. I do have a chat. Oh. Okay.
Thank you so much, Jill.
I hope that was okay.
No, it was good. It was a lot of information. So I think people were doing a lot of processing.
No, it is a lot of information.
Mm-hmm.
And I was trying to keep it like kind of as simplistic as possible, but it is a lot.
Yeah, I
Hopefully
mean,
I
the
just
topic
stressed
itself is
how,
a lot.
yeah, hopefully I just stressed how important it is during this time to make,
No, no. Well, thank you again.
Right, thank
May I
you.
ask a question?
Yeah.
I'm
Oh, yeah,
sorry.
yep. Sure.
Hey, I'm a social worker, clinical social worker on the in a covering the women's hospital at a local hospital, so delivering hospital. There are so many people, it seems like, who are still coming off